Hi. I'm not sure if anybody's going to turn up, especially because it's the PSA lecture tonight as well. So, um, yeah, it's not seeming too likely. Hi, it's Nikita teaching. Oh, cute. Okay, cool. Hi. Is it Izehi? Is that how you say your name?
Yeah, it is.
Wait, my volume is not up. Hold up. Hold up. Okay, go on.
Yeah, it says a he.
Yeah, okay. I think you're the only person that's going to come today. Charlotte is also here, which is why her name's on the screen. Um,
Oh,
she's just gone to the bathroom, but she'll be back in a sec, and then we can make a start.
yeah, that's fine. Okay.
It's gonna be pretty one-on-one. I'm not sure if it's already recording, or if I'm gonna. Yes, it's already recording. Um,
Yeah.
but yeah, it's gonna be pretty much one-on-one, which is
Oh,
fun for you, I guess.
I guess I kind of just I signed up because I have ENT after Christmas, so I just wanted to see what it's like, sort of like. So I don't really know anything.
That's okay. That's okay.
Okay.
No expectations to know anything at all. And making these slides was revision for me anyway. Um, and what I've done is that each slide is basically like the NICE guidelines condensed into one slide. So they look a bit wordy, but really it's all condensed into one. So you can use these as like notes for revision and stuff.
Yeah, that's fine.
Cool.
Yeah.
Once Charlotte comes back, we will make a start.
Okay. Okay.
Hi. We have one person on Zoom. This PC is just not turning on. Smells smoky. It's for a while done. Does it? Wait, let me mute this. Okay, hi everyone. Well, by everyone, I mean one person, which I love very much. Thank you for coming. So this is the penultimate session for this side of the year for ENT, I mean, MedEd Scalpel. So we're going to cover, well, I was going to cover the anatomy and ENT exam, but you get a lot of teaching that. I'm assuming you're in fourth year. Um, and then ears, nose, and throat. It's pretty, does what it, does what it says on the tin kind of thing. So for the external ear, there's three main conditions you need to know, which is otitis externa, malignant otitis externa, and perichondral chondrial hematoma. So otitis externa is just anything itis is inflammation or infection, and that's going to be of the skin of the outer ear canal, and that might include the actual like pinna itself. Or the tympanic membrane if it's gone like all the way down inside. It's often called like swimmer's ear or tropical ear because people go on holiday, they go swimming, and then their ears get infected. So it's split into acute, chronic, and malignant. So acute is less than 6 weeks, and it's often Pseudomonas aeruginosa, or Staphylococcus aureus, which is good for QuesMed, PassMed questions and progress test to just know that, oh yeah, that's the main thing that causes it. And then if it's over 6 months, you're thinking Aspergillus or Candida albicans, more sort of like long term. And then malignant is usually Pseudomonas aeruginosa. Um, so there's lots of different risk factors. So if you have eczema, psoriasis, seborrheic dermatitis, these are all things that can damage your skin barrier, and therefore allow infection to more easily set in. Same with like acute otitis media. If there's infection nearby, it can spread. Um, Same with contact dermatitis. It can damage that skin barrier. Depends on what you're allergic to. Some people can be allergic to nickel, like in earrings and things like that. There are some hypoallergenic hearing aids that you can get because some people can get dermatitis from hearing aids as well. Trauma, so like using cotton buds, things like that. People put foreign bodies in there, and by people, I mean children. And then water exposure, especially if it's dirty water. Um, so there's strict like diagnostic criteria given by NICE. So you can have at least one typical symptom, which is itching of the ear canal, pain, tenderness, jaw pain, if it's, all spread around, discharge from the ear or hearing loss. Because if the ear is so inflamed, like the ear canal is so inflamed, it can become occluded. And then that can give you a conductive hearing loss. Or at least two typical signs. So tenderness of the tragus or pinna, red erythematous, edematous, discharge debris. It's like all the stuff you'd expect. Like if you have an infection of any kind of like dermatitis or cellulitis, it's going to be edematous. It's going to be red. It's going to maybe have some discharge. Tympanic membrane can be erythematous as well, and it can actually turn into cellulitis later, which is a bit more serious. And like I said before, conductive hearing loss. Um, so to manage it, the main thing is just clean, like dry ears. You're not going to want to put cotton buds in there. Don't do that. Don't do that. We know that. I think everyone still does it, but it's fine. It's not fine. Clean and dry ears. You can have acetic acid, 2% eardrops, or it can be a spray, which is a bit easier to like disperse it out into the ear canal, if they're over 12 years. And you can do that like after you've been swimming or after you've had a shower to just help reduce that risk, but it can only be used for 7 days. Supportive management, analgesia, things like that. If they have like a contact dermatitis or something else going on, deal with that. Take away whatever's irritating the ears. And then you've got this lovely thing called an oral toilet, which I love, which is basically just washing the ear out. That's all it is. You can have antibiotics only if there's really bad inflammation, really bad erythema and edema in the ear canal, and that will be topical as well. You can, if it's really quite bad, and this sort of happens when you have like chronic otitis externa and like malignant otitis externa, you can have like an ear tampon almost. So you put it in. It's called an ear wick, and you can drop like the acetic acid or the topical antibiotics into that wick to sort of keep it in there, and it will sort of expand as you add in all of the fluid, antibiotics or acetic acid, and that'll sort of keep that fluid touching the ear canal, so it doesn't just dry up. It's touching it and it continues to work. And follow up in 2 to 3 days if it's not resolved, because you don't want it to turn into cellulitis, which is not good. Chronic. Oh, yes. Sorry, I've got to change it on the other one. So chronic, all the same risk factors, but in this case, you got to look at uncontrolled diabetes mellitus, immunocompromise, things like that. That's why it be chronic. That's why it's not getting better because they're at risk of other things. Constant itch, mild discomfort or pain is usually what it carries on to be. And yeah, signs, lack of earwax, dry, scaly skin. If you think about it, it's irritated. It's been like, inflamed for such a long time. It's gonna start to be dry. It's gonna start to like be damaged and then heal and then damage and heal, and you might get canal stenosis. Being red, moist. It can also start to grow fungus, which is disgusting. So it'll be fluffy, cotton-like debris, hyphae. I've got a picture of what hyphae actually look like. This is stuff you see on like fruit and veg that's gone bad, or black dots of like spores you can see. And then that'll be conductive hearing loss because if you think about it, they've got canal stenosis, it's going to be conductive. You want to do an ear swab to actually give them the right thing to take for it, especially if it's chronic. Yeah, same again, oral toilet. If it's fungal, clotrimazole solution, topical, 2 to 3 times a day for 14 days. 14 days after the infection has resolved. So after you think it's all gone, do it for another 2 weeks. And then cleoquinol, which is both antifungal and antibacterial, with a corticosteroid for 7 to 10 days if you're not going to go for clotrimazole. And then acetic acid, again, if it's not fungal for over 12 years old, 2 times a day after any time after wetting your ears for a maximum of 7 days. If you can't really see what it is and you're like, hey, it's still inflamed, you're going to go with the OG anti-inflammatory, which is corticosteroid. So you've got prednisolone eardrops 2 to 3 times a day, every 2 to 3 hours. And I like it. It's 2-3-2-3. Cool. That's what hyphae look like. It's kind of gross. Imagine that in your ear. Imagine that in your ear. Pretty gross. And that's an earwick, the thing I was talking about where you can like drop the acetic acid or antibiotics in to like, keep it in there. Okay, on to malignant otitis externa. So this is very bad. You don't want this. Nobody wants this. This is when it's spread and can cause osteomyelitis of the temporal bone and adjacent structures. You know, it's not nice. It's also called necrotizing otitis, usually Pseudomonas aeruginosa. And this is where diabetics and immunocompromised comes into play because 90% of patients that have this have diabetes. So control the diabetes, guys. Don't let that go out of control. Not great. Radiotherapy, previous ear surgery, all of those things play a part because you're damaging that skin, you're damaging that area, you're putting it at risk, really. Cool. So you've got facial nerve palsy, which is an early sign. You want to tell me why? Anybody want to tell me why facial nerve palsy might come into play? Like in yeah, sure. Okay, so Charlotte's doing this. So facial nerve, you've got branch of the facial nerve that runs through the ear. And so that's gonna be affected. Headache, purulent otorrhea, which basically just means it's like pus coming out of your ear. And then fever and malaise. Vertigo, which is like the room spinning around you, and profound conductive hearing loss. You can sometimes see granulation tissue on the floor of the ear canal, but you may not always see granulation tissue. And then exposed bone if it's really bad. And then, yeah, facial nerve palsy on the same side. You want to do a CT scan. You want to see how far that's spread. You don't want it to be, spread really far out, really bad osteomyelitis, can turn into meningitis. You don't want any of that. Urgent ENT referral and antibiotics, IV. Cool. Oh, a question. What do you think it is? You've seen the answer. Um, yeah, so this is a pinahematoma. It usually happens, in fact, I'll go on to the next slide. You wanna incision and drain that. So perichondrial hematoma is basically you get ear trauma, like boxers normally get this. get punched in the ear. There's shearing forces on the auricle, which basically just means like, ripping forces. And the blood vessels break. A hematoma forms between the cartilage and the perichondrium, and then that causes lack of blood supply, which can cause avascular necrosis. And then that causes fibrocartilage overgrowth, which is not nice. And it forms that cauliflower ear that we learned in which year? Second year? Um, you want to drain that hematoma, and then apply pressure dressing so that the hematoma doesn't come back straight away and just cause it again. And also incision and drainage has shown to be better than fine needle aspiration, unless the hematoma is really small. If it's really small, then you can get a little needle and do it. Otherwise, you're going to want to incision and drain and apply pressure dressing. Anyway, that's it. Onto the middle ear. So, otitis media, sometimes with effusion or perforation, mastoiditis, cholesteatoma, and otosclerosis. So, otitis media, sorry, this is a really wordy slide. It's not very nice, but it is what it is. It just means inflammation of the middle ear, which can have effusion, and it's usually really quick onset. If it's recurrent, you would want to say that you have 3 or more separate episodes in 6 months. That means that you fully resolve that otitis media and then you get another one. There shouldn't be like residual symptoms. It has to be completely separate, or more than 4 in the last 12 months. With 1 being in the last 6. It's usually bacterial. So what can happen is you can have a viral respiratory tract infection, be ill, but you will get a secondary bacterial infection that causes the otitis media. And it's usually Streptococcus pneumonia, Haemophilus influenza. The other 2 don't need to remember. You need to know the main 1 or 2 for past med questions. And then viral can be RSV, rhinovirus, adenovirus, flu virus, lots of viruses, but it's usually bacterial anyway. Children have it more. Anatomy, their eustachian tube is horizontal, short. They're little, cute. They're small. And if they're a child, they're going to be pulling at the ear, tugging at the ear, crying, having a fever, not feeling too well, breathless. And you do want to look out for a recent upper respiratory tract infection. So when looking on otoscopy, you can probably see a red, yellow, or cloudy tympanic membrane. It might be bulging if there's fluid behind it, or if it's really, really inflamed. And you can see an air fluid level if there is an effusion behind it. If it perforates because of that increased pressure from all the fluid, you might see that come out as otorrhea. Yeah, so usually self-limiting. You don't normally really need to give antibiotics ever. Paracetamol or ibuprofen just for the pain. And if they're under 18, you can give analgesic ear drops. So long as there's no perforation, because if there's a perforation, you don't want it going into the middle, like actual middle ear. Admit if they're a really tiny baby, if they're less than 3 months, or admit if they're 3 to 6 months with a high fever over 39. You can give a delayed antibiotics prescription, I can't speak, prescription, if they're not improving, or if it worsens after 3 days. And when I say worsens, I mean it gets really bad really quickly. Yeah, you can give it then. And that would normally be amoxicillin for 5 to 7 days, or clarithromycin if they're allergic to penicillin. If it's recurrent, suspect a malignancy. Don't just ignore it. Not great. And if they have a craniofacial abnormality, that can also play into things. What is happening next door? And do an ENT referral. So this is what it looks like. So this is the middle ear. Between here, you've got your malleus incus and stapes. Stapes is a little one at the end. And then this is the tympanic membrane. So you're going to have that loss of that cone of light. You're not going to be able to see many of the structures on the inside. It's really red. It's bulging. It's not happy, It's not happy. So mastoiditis is basically from the middle ear, you have the mastoid air cells that are sort of like on top of it. And so the air cells themselves are to allow air to move from those cells into the middle ear if the pressure changes. So it's like a backup air that you can use if you need it. Say if you're like going up in altitude or like under pressure, right? No, maybe, I don't know. But it's to allow increased air to, if aeroplanes, yeah, increase in altitude. And when it hits those massive air spaces, it can sort of stay in there and then spread to the temporal bone, which is also not great. Um, it's going to be really painful. You're going to look for recurrent otitis media. If they're having it a lot, they're more likely to, it's more likely to spread. Really, really, really unwell. They're not going to be happy. Like if you see someone with mastoiditis, they're going to be very, very unwell. And when you touch it, it's going to hurt. And the ear might be coming forward a little bit. I love that I'm doing this when I'm wearing a hijab, so no one can actually see my ears. So diagnosis is usually clinical, and you want them to really urgently go to ED, say if you're in GP land, or have an urgent ENT referral and have them be seen. And you want to be able to do a CT as well to see if there's any complications, namely meningitis. You don't want meningitis. You don't want facial nerve palsy. You don't want it to start affecting any of the nerves, especially like vestibulocochlear nerve. High risk. IV antibiotics straight away. Don't delay that. So this is what it looks like. So these are the mastoid air cells, and that's the going temporal bone, and then that's your tympanic cavity, and then that's where it can spread, which is not good. Yeah. So next, cholesteatoma. So there's cholesteatoma, and then oh gosh, and then otosclerosis, right? So the cholesteatoma is the skin cells themselves. So skin is keratinized squamous epithelium, isn't it? So that grows too much in the middle ear, and can be in the mastoid air cell, like spread there. And because there's such an overgrowth, that debris kind of just stays and then causes inflammation. And it's not happy. It's really not happy. Usually you can, wait, sorry. Um, you can have it from getting otitis media chronically, because, you're damaging it. It gets better. You're damaging it. It gets better. Like things are going to go wrong. And it can also be congenital, but that's very rare. Yeah, what else? Different places it can be. So you've got the attic sinus and tensor. I thought I was going to have a diagram of what the attic means, but we've got to think back to year two anatomy for that. Um, and you're going to have purulent ear discharge. It's it's kind of smelly. It's not great. It's, you're going to think about if someone's not getting better. If they're refractive means you're treating someone for something, they're not getting better despite treatment. So otitis media or externa. Yeah, really smelly. It's unpredictable. So it's not like you're ill and then you get it and then, it goes away. It's just randomly happens and you're like, oh my God, what's this coming out my ear? It's gross. Yeah, progressive hearing loss because as it grows, you're going to progressively occlude it, and it's going to be conductive hearing loss. You might have some tinnitus, ear pain, vertigo, if there's facial nerve involvement. And by that point, you shouldn't really get to that point. That's bad. Don't do that. I say that like you can stop it, but you can't. But it's okay. So you might see a yellow-white mass behind the tympanic membrane, which is it is the like cholesteatoma itself. A retraction pocket, right? I had to like really understand what retraction pocket is. So it can happen as you're growing, like from a fetus, where the tympanic membrane sort of like comes in on itself, and then you're left with a little pocket. So if you get one of those, then that can increase your risk, and you can also have it like in there. And then you'll have that's meant to say accumulation and of. Okay, anyway, crust and debris can be in that pocket and might have pus surrounding it. And you might get a perforation because, if it's in the tympanic membrane in the retraction pocket, it might, come out. And then management, urgent ENT referral, especially if they have facial nerve involvement or if it looks infected. Otherwise, quite prompt referral. They're going to need audiology done, CT and MRI to see if there's any erosion of the bones, and surgery to remove that buildup. Yeah, it can be invasive. Whatever. You can do that. It's not that important, right? It is important, but it's not that important. Okay, this is what it looks like. I tried to give you a trigger warning because it's kind of gross to look at. Yeah, gross enough. Okay, bye. Next thing. Autosclerosis. So that one was overgrowth of keratinized squamous cells, right? This is overgrowth of bone. So this, and then it affects the ossicles, which are the three little bones in the middle ear, and it can often cause fixation of the stapes. So the stapes is this little bone at the end, because it, yeah. Wait, I'll show you one. This one, the baby one. Um, yeah, you can have a family history of it. It's transmitted autosomal dominantly, and usually you're within 30 to 50 years old. So it's got to be quite late on in life to be like, okay, something's growing now, it's affecting me. Not great. Really, really gradual onset, starts unilateral, then becomes bilateral, and it's completely painless, and you'll have conductive hearing loss because it's middle ear. It's going to be conductive. Really less common, like signs as tinnitus and vertigo, but it's very rare. It's usually just the gradual onset, unilateral to bilateral hearing loss. No, pretty normal ear exam. And yeah, you're going to go by clinical examination, and then audiometry will just confirm that conductive hearing loss. Sometimes do a CT, but it's not really often that often done. You can give them hearing aids to help, and then you can also do what's called a stapedectomy, which is where they go in through the ear canal. They make a little incision just above the tympanic membrane. They go in, they take out the stapes, which has become fixated, and they replace it with a little synthetic stapes. And it's so tiny. It's like even like this small on my finger. It's teeny tiny. Yeah. So this is just a reminder. Cholesteatoma is skin, otosclerosis is bone. But with Otto, you're gonna think bone anyway, right? Cool. Ear balance stuff. So you've got acoustic neuroma, labyrinthitis, vestibular neuronitis. Sorry. Yeah. Meniere's, BPPV, BP. How many P's did I say there? I don't know. Ramsey Hunt. Ramsey Hunt, less important, but it's there. Just so you know what it is. And then dizziness there's the differentials just for you to think of when you refer back to these slides later. If anybody ever refers back to the slides later. Cool. So labyrinthitis. So that's infection or inflammation of the membranous labyrinth, usually viral, can be bacterial, but usually viral. If the vestibular nerve is involved as well, then you're going to get vertigo. And if the labyrinth is involved, which it is because it's labyrinthitis, you're going to get hearing loss. Usually viral, can happen from acute otitis media. Yeah. So it happens usually very acutely. It so if you think about it, right, the labyrinth has fluid in it. So if you move, it's gonna make you feel dizzy. So anything to do with fluid, with that endolymph that's inside, it's going to make you dizzy. You might have nausea and vomiting, hearing loss. It can be unilateral or bilateral, depending on whether you have one like unilateral labyrinthitis or bilateral, with or without tinnitus, and it's going to impair your balance. And usually you'll have a upper respiratory tract infection just beforehand. So you have spontaneous unilateral horizontal nystagmus towards the unaffected side, and that has to last for over a day. It can't just be like really transient. You have sensory neural hearing loss and gait disturbance affecting one side. And the vestibulo-ocular reflex test, which is this really funky picture here, you do that test, you move the head, and then you can like look at their eyes. Wait, if I just get it up here, I can tell you exactly what you're meant to do. So yeah, you rapidly move their head from to one side, and then you watch their eyes. And if their eyes stay fixed on you, then that's normal. But if their eyes are dragged off away from you, that means that they're not able to coordinate like the vestibular movement with their eyes. That's why it's a vestibular ocular reflex. So normally if I move my head this way, I can still move my eyes this way and like look straight. Does that make sense? I hope. Um, Cool. So usually it's clinical diagnosis, history, and examination. And you're going to get sensory neural hearing loss when you do René's and Weber's. And I'm going to go over that as well, so you'll know exactly how to do that. Cool. It's usually self-limiting. You can give prochlorperazine for nausea and antihistamines for dizziness, but they're self-limiting anyway. Cool. Let's put this back on for you. Vestibular neuronitis is inflammation of the vestibular nerve itself, and that can happen after a viral infection or secondary to ischemia. Because it's the nerve only, you're going to have vertigo. The cochlea is not affected, so you're not going to have any hearing loss. So back here, you had vertigo and hearing loss. Here, just vertigo, no hearing loss. Your hearing's fine, and it's going to be unilateral, and it's going to affect your balance. It's going to give you vertigo, nausea, and vomiting. The same head impulse test is going to be positive. You're going to have unidirectional, horizontal, or rotational vertigo. Rotational vertigo is where your eyes are actually like slightly rotating. Um, yeah, cool. Um, and it's pretty spontaneous, can worsen throughout the day, exacerbated by head movement. And you might have like autonomic symptoms because you're affecting nerves. So, you know, no focal neurological signs or hearing loss. So that's really important. So if you've got a past medical question that's like, hey, I have like vertigo and hearing loss, you might be thinking more along the lines of labyrinthitis. But if they've made a point to say there's no hearing loss, there's no focal neuroscience, you might want to think more of vestibular neuronitis. So 2 to 6 weeks usually settles on its own. Have some bed rest because you're going to be feeling really awful, really dizzy. It's not nice. And then also safety wise, make sure you're not driving. And also the driving is going to make you more dizzy because it's affected by movement. So don't do that. And also inform your workplace if you have any risky, if you're driving any machinery or whatever. You want to give prochlorperazine again or cyclizine. You want to kind of give it quite fast, so it'll be intramuscular because you're feeling really, really quite awful. And then yeah, you can give oral after that for up to 3 days. But there's some evidence to say that this might delay your recovery. I don't actually know why, right? I don't know why it would delay your recovery, but if you need it for the nausea and vomiting, take it. I'm sure it feels horrible. And then, yeah, admit if they're severely dehydrated from vomiting, and you can do vestibular rehabilitation, which basically is helping them to regain their balance and like learn how to do things again. Yeah. Cool. This is just the same thing. The way I remember it is like labyrinthitis is loss, so hearing loss is LL, and then neuronitis is no loss. So NN, I guess. Cool. Acoustic neuroma. I'm gonna take my jumper off. It's really, it is a cute jumper. Thanks, Charlotte. Would you like to wear it? Okay. So, acoustic neuroma is a benign, slow-growing Schwann cell neoplasm. So the Schwann cells are the ones outside of the nerve, and that's good. That's growing. And that looks great on you. Yeah, and it can compress the nerve, which can cause deafness. I can't remember if that deafness is permanent or not. Wait, can I see on here? Meh. I don't know. I don't know. Anyway, it's also called a vestibular schwannoma. And there are some. Okay. So 40% of patients will have a defect in chromosome 22. How are we doing for time? I don't know if I'm going into too much detail. Yeah, gradual onset, unilateral sensorineural hearing loss with tinnitus and vertigo sometimes. If you think about it, right, you've got a nerve, it's got a benign tumor growing on it, it's compressing that nerve. So it's going to be on one side because the tumor's on one side, and it's going to be sensorineural because it's putting pressure on the nerve. Um, yeah, it's permanent. That's crazy, man. Um, if it's large, you might get headaches, double vision, numbness, pain, weakness, unilateral ataxia, dysphagia. Hydrocephalus is very, very, like very rare, but not very likely to get that. And you'll probably have a normal ear exam because from what you can see on an otoscopy, the outer ear, the middle ear, you can't see the nerve. You're not going to be able to see anything. But it will show sensorineural hearing loss when you do like audiometry and Renes and Webers. and you might have some focal neuroscience if it's advanced further into the cranial fossa. If it's gone really down, it can like put pressure on the cerebellum or brainstem, and then you'll have like gait abnormalities and things like that. Um, MRI is the gold standard because you're looking at a soft tissue element. So CT will be looking at bones mainly. And yeah, so you want to see that on an MRI. If it's really small, you can just leave it be and just monitor like it regularly. And if not, you can do stereotactics radiosurgery, which is it's like wait, what is it? There we are. I was on the wrong side. Yeah, so that's just radiotherapy on the small tumors. And that's if it's very small, or if you've gone in, removed it previously, and there's little pieces left. But with surgery in general, especially in the ear and like in small places, you're working on a nerve as well. You don't want, it's a risk of paralysis, and you don't want to go too close to that nerve. Cool. So this is what it looks like. So as you can see here, the vestibular nerve here, it runs just above the cochlear nerve, and that's why you have vestibular cochlear because they're like side by side. And then here's the neuroma, and it's putting pressure on that nerve here. Okay, Meniere's. This is so everybody mixes up Meniere's and BPPV. Benign paroxysmal propositional vertigo. Meniere's, they don't really know why it happens, but it's to do with like the fluid in the labyrinth of the inner ear. So they're thinking that there's too much fluid that causes distension and rupture of Reisner's membrane. Reisner's membrane is the membrane that is in between, like it separates the cochlear duct from the vestibular duct. And basically, what it does, it helps transmit vibrations from the fluid to the cochlear duct. So if you're not able to do that, right, if you're not able to transmit those vibrations, then you're probably going to have hearing loss, right? Because, you're not able to do that. And so then what can happen after that is that endolymph, because it's ruptured that membrane, is then released into the perilymphatic space, and that causes injury, and then you'll get sensory neural hearing loss. Because it's affecting fluid, you're going to be dizzy. Anything affecting fluid in the ear, you're going to be dizzy, right? You're going to have vertigo. You're going to have fluctuating unilateral hearing loss. This is such a like core thing of many ears is that the hearing loss is fluctuating. The tinnitus, they often call it roaring tinnitus, and then your ear will feel full. Roaring, like yeah. Usually unilateral, but it can be bilateral, and it's usually spontaneous. And after your attack, you can still have dizziness for a few days after that. And usually the symptoms will be in this order. It'll be tinnitus, hearing loss, oral fullness, then vertigo. Cool. It usually lasts around 20 minutes, 2 hours, but it will never last more than a day. If it's lasting more than a day, yeah, you should be thinking of other differentials. And you can have quite a few within a week, and then a period where you don't have any, and then quite a few in a week. So there's a lot of like patterns you can recognize in this, like the order of the symptoms, the clustering, the fluctuating hearing loss. And then you can have nystagmus as well. Um, um, yeah. And because you have balance issues, rhombo is going to be positive. Tandem gait, which is where you put one foot in front of the other, that's going to be affected as well. You need to have all four of these criteria to diagnose it. So two or more spontaneous vertigo episodes lasting between 20 minutes and 12 hours. Audiometry that shows sensory neural unilateral hearing loss, and that's either like shortly before, during, or after the attack. And then fluctuating oral symptoms, like the oral fullness, all that stuff. And there's nothing else it could be. You want to do an ENT referral for confirmation of diagnosis. And the acute attack should resolve by itself. If you have recurrent attacks, you can give beta histine. Hi. And that can reduce the frequency and the severity of attacks. and you can give prochlorperazine for nausea, vomiting, and vertigo, stuff like that. Make sure you contact TBLA if you're driving, especially if driving is your job, and if you're, running heavy machinery. Oh, sorry. Sorry. Yeah, because if you can imagine, if you get dizzy for like 20 minutes at a time, you shouldn't be driving. Really, you shouldn't be doing that. Cool. BPPV. I love BPPV because it's all the letters. You have B, you have D, you have E, right? So you have B for BPPD, BPPV, right? No, no. Hear me out, hear me out. You have D for Dix Hallpike. You have E for Epley. There's like all the letters. Yeah, I mean, I have lots of hobbies actually. One being medicine, I guess. So this is where you have the loose calcium carbonate debris called otoconia that are in the semicircular canals of the inner ear. Usually, if you got to be old, you got to be old to have this, guys. Got to be old. 55. Look, right, when I'm 55 and I'm alive and kicking. That's crazy. Anyway, yeah, you got to be over 55, guys. I'm not being ageist. It's just a thing. Okay, right. The main thing with this is positional. It's in the name, guys. You move your head, it comes on. Because it's semicircular canals, and they are like your gyroscope, and if you've got stuff in the gyroscope, you're not going to know which way's up. So you're going to be dizzy, right? You're going to move your head, you're going to get dizzy. It's really short, guys, really, really short. 10 to 20 seconds, hearing's not affected. You might be nauseated, and typical past med question, they're rolling over in bed, they get dizzy. They move, they turn to look at someone, they get dizzy. So yeah, diagnosis is Dix-Hallpike. And the way you can remember it is it begins with D, so it's diagnosis. And also, D comes before E. Diagnosis comes before treatment. So Dix-Hallpike comes before Epley. Lots of ways to remember it, right? It's great. Such a good way. You'd have rotatory upbeating nystagmus, and yeah, repeat it if it's negative. Don't just be like, hey, they didn't have that, so they don't have it. And then Epley maneuver is successful in 80% of cases, and that's for like symptomatic relief. And you'll have like periods where you have it, and it spontaneously resolves. You may not ever get it again. You might get it again. Who knows? And you can do like some exercises like Brandt Daroff. How you do that, God knows. But they can do it themselves at home, and that gives them symptomatic relief as well. Next slide, my guy. We're going to explain that. DVLA advises to stop driving because, like, stop driving if you have BPV and you're liable to sudden and unprovoked episodes of disabling dizziness. The wording is so specific, but and also they're going to be at risk of falls. Be careful. Make changes to the house. Ask about their job. Anything that I've talked about that has vertigo in this so far, just talk about falls. So this is how you do Dix-Hallpike. So you sit them up, you turn their head 45 degrees, then you make them lean their head back 30 degrees, and then you lie them down quickly. And then you're going to look for nystagmus. And then Epley maneuver. I try to understand Epley maneuver, right? We're never going to need to do an Epley maneuver in our lives unless you go into ENT. You saw it. Nice. So you turn the head, you lie them down, then you put the head. This picture doesn't show it very well, actually, but you're actually meant to put the head back off the end of the couch so that the head is extended 30 degrees backwards as well. Also, if they have like cardio stuff, don't do this. Or like neck, like cervical spine stenosis or something, don't do this. And then you rotate it in various different ways, and it gets better. That's all you need to know. That's all you need to know. I have more information under the slide here. Yeah, look at the eyes. Yeah. If it's left, it'll be clockwise. If it's right, it'll be anti-clockwise when you do Dix-Hallpike. Cool. Next slide. I don't want to spend too long on this because we've got a lot to cover. Ramsey Hunt, really short slide, guys. Yeah. Herpes zoster oticus, so it's reactivation of varicella zoster virus in the geniculate ganglion affecting the facial nerve and vestibulocochlear nerve. So you've got two nerves involved. You'll have otalgia, facial nerve palsy. Can you guys tell me, is the eyebrow spared or not spared?
Is it when it's upper? It's when it's
When it's
Wait.
lower, because you're affecting the nerve itself, so it's going to affect all of it. Whereas if it's upper, you have crossover.
Oh wait, yeah, I meant 5 minutes. I know.
Okay, cool. Cool. And then you'll have this vesicular eruption, so you can see it on the.
There's conversation.
So, like when you have a stroke, no?
Yeah, what's that one? What's the syndrome? It's a different one.
Bell's palsy? Is that what you're thinking of? No.
I don't know what I'm thinking of.
Okay.
But I'll have a
Should we come back to it later?
Like you can look at the wrinkles in the forehead.
Yeah. So anyway, Ramsay Hunt, forehead is also involved. Just remember that. Yeah, vertigo if you have a vestibulocochlear involvement. So basically, if they've had varicella zoster virus in the past, just make sure you ask about that. And then you might have reactivation. Cool. So we're on to hearing loss now. We're going to cover Rinneys and Webers. There's differentials here. There's drugs that cause ototoxicity and the criteria for what sudden onset means and what the different hearing loss things are. This is just so you can refer to it later, but we're not going to go through that. So Rinneys and Webers, I really like this actually because I feel like it confuses a lot of people, but once you get your head around it, it's actually fine. So Webers is when you put the tuning fork on the middle of your head, right? Usually, air is going to be louder than bone conduction. Air is louder because, hi. Okay. Air is louder because your ear will catch that vibrations. It will go down the external auditory canal. It will go through all the ossicles, and the ossicles are made to everything anatomically is made to increase those vibrations. And so if you have conductive hearing loss, that conduction down your ear canal and all of the ossicles is going to be affected, right? So that's why bone will be louder because you're relying on the bone to give you the sound. So you put it in the middle, right? If it's louder in one ear, that means that ear either has a conductive hearing loss or the other ear has a sensory neural hearing loss. So either it's not conducting air very well, or you're deaf in your left ear, so it's gonna sound louder in your right ear. If that makes sense. Then Renee's is you're gonna hit the tuning fork again, put it on the mastoid bone, right? Until you don't hear the sound of the vibrating fork. It will still be vibrating, but you can't hear it. And then at that point, you move it to in front of the ear and see if bone is louder than air, then you're thinking conductive in that ear. So say my right ear was louder on Weber's, and then I did Renee's, and bone was louder, then I've confirmed that it's conductive. But if air was louder than bone or they were equal, then I don't have conductive in that ear, and that indicates that I have sensory neural in the other ear. I hope that makes sense. I hope. Tell me if it doesn't. Cool. Presbycusis is just age-related hearing loss. It's sensory neural in nature. And you're more likely to get it if other people in your family have had it. And it's usually between 50 and 60 years old, bilateral progressive. They might notice actually. So they'll start putting the volume up and they don't really realize they're doing it. And then family and friends will be like, hey, I don't think you can hear me very well. Or oh, they've got the TV volume really hella loud. And on like an otoscopy, it's going to be pretty normal. And then you're going to do a routine audiology referral for pure tone audiometry and then hearing aids if you can't find any other cause for it. But that's pretty much it. Cool. Onto the nose. So let me know if you guys want a break. If not, we'll just keep going. So sorry. Nose has quite a few, and then throat has quite a few. No, nose is actually quite short. There's not too much to it. There's a couple of like small conditions. 7 minutes. Okay, cool. Cool. That's fine. Bleeding from the nose. Right. You can look at this later. I'll shorten it down for you. Right. Little's plexus, anterior part of the nose. That includes, Little's area, sorry, includes Kisselback's plexus. And that is like really, really superficial, can easily break, and you can see it, right? Cocaine is a vasoconstrictor, and that can cause damage to the area, and it can cause so much damage that it can cause perforation sometimes. If it's anterior, you'll see it. It'll be Kisselback's plexus. If it's posterior, it'll be the sphenopalatine artery. You can't see it, right? And it's going to be bleeding a lot. They're going to be swallowing blood. There's going to be an asphyxiation risk. If you're going to put pressure on the front of the nose, you're going to tilt your head forward and lean forward. That reduces the blood flow to the nose and also allows you to like cough out blood if you need. And you need to press the soft part of the nose. Yeah, you've got silver nitrate to cauterize it if you can see it. If you can't see it, nasal packing. If nasal packing doesn't work, you're going to go for you can do a rapid rhino, which is basically you put a thingy in the nose, you inflate it, and it puts pressure on it. If that doesn't stop, they need to go and get their sphenopalatine artery ligated. Right. Cool. That's it. That's all you need to know. More information on the slide. That's what it looks like. He looks way too happy to be having that put in his nose. Rhinosinusitis is inflammation of the mucosal lining, whatever. Acute, less than 12 weeks. Acute viral is usually less than 10 days. Acute post-viral is they've had a URTI, then they've had 5 days, of worsening rhinosinusitis, and persists after 10 days. Sinusitis, same thing. Rhinosinusitis is just the more like apt name now for it.
So not names. Do we have a status?
So on NICE-CKS, it has it listed as sinusitis, but it has a note underneath it saying rhinosinusitis is the actual name for it. We've just put sinusitis so that people recognize it. So yeah, 12 weeks.
Sinusitis, rhinitis.
Because they're saying that when you have sinusitis, you pretty much always have rhinitis. So that's why they've said that. Cool. More than 4 episodes a year is recurrent, usually rhinovirus, usually viral, not really like bacterial, yes, usually viral. And it's usually Staph aureus in children. Smoking, cystic fibrosis, anything that affects the cilia is going to affect this. Cool. So much information. Why did I write so much, my guys? Main thing, facial tenderness, right? You're going to touch their face where the sinuses are. It's going to hurt. They're going to lean forward. That's going to put pressure on those same areas. It's going to hurt. Yeah, they might have like jaw pain as well, like jaw and teeth pain. This is the diagnostic criteria: nasal blockage, nasal discharge, facial pain, anosmia. And for children, you add a bit of cough in there as well, right? So usually viral, it'll resolve by itself. Bacterial sinusitis is also self-limiting. You don't need to give antibiotics. You just don't need to give antibiotics. They'll be fine. Paracetamol, ibuprofen, or saline irrigation of the nose, basically. So saline nasal or decongestants. Corticosteroid if it's been more than 10 days, and backup antibiotics if they're immunocompromised, if you're really thinking it's bacterial and they've gotten really bad, or if they're systemically unwell, and that would be phenoxymethyl penicillin. Chronic, all the same things, but if it's unilateral, just always consider malignancy. Yeah, lots of stuff on there. Corticosteroid, reduce that inflammation. Allergic rhinitis, same thing, but happens from allergies, hay fever, occupational irritants, stuff like that. You're just going to give intranasal corticosteroids. Most people will do just fine with that, and it'll help in the long run. You can give nasal decongestants, but be really careful. It should be less than 7 days course, because you can get rebound hypertrophy of the turbinates, and that's going to cause them like blockage of their airways anyway. Yeah, cool. And they're going to need more dose to like feel the same effect. Polyps, yeah, most like 1/3 of people with polyps also have asthma. So just, check the past medical history. It's slow progressive, usually bilateral. If it's unilateral, think malignancy. Bilateral, think polyps. Pale grey, yellow, and the turbinates will be normal pink. Nasal corticosteroids will shrink it in 80% of people. So long term, like spraying up the nose should help. Sometimes oral if they're really bad, and ENT referral if any red flags, or if it's like so bad they just can't breathe. This is just a pathway that I found. It's basically anywhere you go, corticosteroid spray. You go down this side, corticosteroid spray. You go down this side, corticosteroid spray. There's just no. It's just the same. But if they have severe deterioration, you can have oral pred sometimes. Sometimes. Cool. Septal deviation can be developmental, cleft lip, palate, craniofacial deformities, or trauma. It's usually unilateral, but if it's really tortuous, you can have bilateral. Funky nasal septum. It's clinical assessment, like clinical diagnosis, and you can give them a saline nasal spray and a steroid spray to reduce the inflammation of their turbinates. Not that their turbinates are inflamed, but to just make them less big so that they can have better airflow. And if it's really severe, then you can give a ENT referral. What's to look for, Charlotte? You okay? It's to be anti-inflammatory. It has to be inflamed, I know. Look, nice. Take it up with nice TKS, please. Septal perforation, basically the whole thing. Like you've made a hole in your septum. Trauma, picking your nose, cautery. So when you're doing like epistaxis treatment and you're doing the thing, don't ever do it on both sides. Because if you do it on both sides, it's going to meet in the middle. So try and find where it is and cauterize on one side. Chronic infection, or like also EGPA, GPA, all the like vasculitis stuff. Remember, like the nasal thing, the crusting, all of that stuff. It's disgusting. He looks me dead in the eye. Cocaine again, back to cocaine. And then chronic nasal decongestant use can also do it. If the hole is small, you'll have whistling. If it's big, you'll have like a saddle nose, which is like the soft part of the nose like starts to go in because there's nothing holding it up. It's really, really hard to repair. In fact, Nice said it's almost impossible. So saddle nose with volunteer associate. Septal perforation. Yeah. Yeah, routine ENT referral unless you have a saddle nose, and then otherwise you do urgent. Nasal septal hematoma, basically you damage it. There's like shearing forces on the nose, and then that causes the blood to come out. It's exactly the same as the perichondral hematoma. Basically, if you don't take that blood away, you can cause septal ischemia. Exactly the same with the perichondral hematoma. You don't take that blood away, it's going to cause avascular necrosis. So you want to take that blood away, you want to put pressure on it, and yeah, needle aspiration for small hematomas, and then incision and drainage for large. Exactly the same as the ear. And nasal packing so that it doesn't start like blood doesn't start coming out again and forming another hematoma. And then you remove that packing after 2 to 3 days. Yeah. Foreign bodies, really cute. Kids will do it. They'll put anything up their nose. They'll put anything in their ears. Um, so with the nose, basically, you can just have them close one nostril that doesn't have the foreign body in it, and just ask them to gently push out. And it can come out that way. If not, you can use like a right angled, what's it called? A little right angled tool, and you can like look up the nose with a light and a nasal speculum and take it out. And then the parents kiss, I think, is really cute. So, well, it's not cute, it's kind of gross. But they put their mouth over the kid's mouth. They close the nostril that doesn't have the foreign body, and they'll push air into their mouth slowly. They'll feel a bit of like resistance, and that's their glottis closing. And then they'll blow really hard, and then that'll push out the foreign body from the nose. And you want to check the septal perforation after that. I heard a story of a little kid putting a little like circular Lego piece up his nose, and it just fit really perfectly. And then they got it out, right? They got it out. And then they go to throw away the Lego, and before they can throw it away, he like picks it up and he's playing with it again after it's just come out his nose. Anyway, it's fine. Ears is basically the same thing. You can do irrigation of the ears, but don't do it if you think there's tympanic membrane perforation because you don't want to get water in there. If it's okay, this is really gross. If it's inorganic, you can use water. If it's organic, you got to use oil. and it's got to be warm. And Nice decided to talk about insects, but I'm not going to talk about that. This is what it looks like, the right angled hook that I was talking about to take stuff out. Nasopharyngeal carcinoma. Basically, anything unilateral in the face, in the body, you're going to think malignancy. Hearing loss, nosebleeds, headaches, double vision, numbness, all this stuff, right? Interestingly, it said South Chinese or North African descent and high salt cured meats will increase your risk of getting this. And also breathing in formaldehyde. So don't be in the anatomy lab too long, guys. Diagnosis is done via nasoendoscopy, MRI, CT, PET CT, just depends. And then eventually biopsy. That's the main thing. Radio and chemotherapy are done. Surgery is very difficult because if you can imagine, you're going up the nose, right? Really small space, kind of hard to take stuff out. So radiotherapy and chemotherapy are like the mainstay of treatment. Also, stop smoking. Don't do that. Don't do that. Don't smoke, guys. Do you want a break? We don't have time for a break. Throat. Yeah, tonsillitis. Look, it's a trigger warning. So usually adenovirus, common colds. If it's bacterial, it'll be group A strep. Centaur and fever pain are your main like criteria to look at. If centaur's above 3 or fever pain's above 4 or 5, then you can give antibiotics. If not, consider delayed. If it's like 0 to 1 or 0 to 2, don't give antibiotics, guys. Don't do it. They don't need it. Um, yeah, cool. Usually phenoxymethylpenicillin, and tonsillectomy. You can only do a tonsillectomy if they have sore throats that are only due to tonsillitis. It's recurrent, so they have 7 episodes in 1 year, or 5 episodes a year for 2 years, or 3 episodes a year for 3 years. And their sore throats are disabling and they can't do the things they need to do. Then you can do tonsillectomy. And also, if they have recurrent febrile convulsions, if they're a small child, then you can take them out. Just throw them away. Cool. That's what it looks like. That's bacterial. If you see exudates, think bacterial. If you don't see exudates, think viral. Cool. That's the fever, pain, and central criteria. Bye. That's GMMC. I love this. So Greater Manchester antimicrobial guidelines. Amazing. Just always use it. It's so good. Because you don't even need to look up fever pain. You can just see it on the guidelines, which I love. Peritonsillar abscess is basically tonsillitis that's gone too far. Most common in children 2 to 4 years of age, and that'll usually be a bacterial. So when you have a quinsy, it's usually bacterial. Group A strep. Tismus is not meant to say tismus, it's meant to say trismus, which is like a locked jaw. Muffled voice, which is like that hot potato voice that I like to talk about. But that's more in epiglottitis, but you can have it sometimes here. Displaced uvula away from the abscess. Why? Because it's pushing on it. That's it. It's just big. It's pushing on it, it goes away. Away from the midline. And also sepsis, dehydration, airway compromise, scary stuff. You don't want any of those things. It's just gonna be cool. Yeah. Clinical diagnosis, hospital urgently, broad spec antibiotics, analgesia, hydration. Because if you think about it, it's so big. They're probably not eating, they're probably not drinking, they're probably drooling a lot. And then needle aspiration, incision, and drainage, they're both fine. There's no evidence to say one is better than the other. Some people used to say that final needle aspiration has a higher recurrence rate and incision and drainage has a lower recurrence rate, but also increased infection rate. Nothing. There's no evidence, guys. Well, there's some evidence, but like there's not enough consistent evidence to show that. So do either one. Take your pick. Cool. That's what it looks like.
Doesn't even look like an apple.
No, it doesn't, does it? She big.
Oh wait, there we go. We're looking at it from like that way.
It's kind of, yeah.
The light's there.
Yeah.
That looks like a dark cave.
When you have quinsy, I feel like the world feels like a dark cave. Not that I've had quinsy before. Cool laryngitis. The larynx, inflamed, infected. It's in the name, guys. It's in the name. So you'll have edema of the laryngeal lining, increases pressure, harder to make noise. You can have it from just using your voice really much, like a lot, and just malusing it, and it can just cause inflammation. But it can also happen from GORD, so that increased like reflux. You can get reflux laryngitis. You can have trauma, smoking, obviously, and ACE inhibitors can give you a dry cough. So like Ramipril is going to give you a dry cough. You keep coughing, you damage your larynx, can cause inflammation. Usually viral, sometimes bacterial, but if it's bacterial, it's usually with a viral. Um, and you'll have hoarse voice because obviously it's your larynx. And upper respiratory tract infections, if it's infective, dysphagia, so trouble swallowing, and continual throat clearing. That's often always the like case with like GORD and stuff as well. Muscle pain, fever, fatigue. Usually clinical diagnosis, only swab if you think there's exudate. Usually self-limiting, vocal hygiene, so resting your voice, avoiding smoking, avoid alcohol because it gives you dehydration, humidify your voice, reduce caffeine, also dehydration, and voice therapy if it carries on for a long time. Head and neck cancers. This is just a summary, right? Everything ends up leading to biopsy, guys. Everything will be biopsied. Um, and I'm sure you can just read them. It's just neck lump over 45, unexplained hoarseness over 45. Um, Oral cancers are usually referred to us by dentists. So dentists will be like, hey guys, I think something's not quite right here. Can you have a look? And I'll show you what I mean by like the red white patch, erythroplexia or erythroleukoplakia on this picture that is conveniently being covered because it's really gross. Um, yeah. So three, two, one, guys. Oh, not as gross. I had options to choose a worse photo, but I chose a mild one.
Massively high.
No, I looked at really gross ones. And I think at that point I was a bit too grossed out. So I chose a less gross one.
The average, like, oral dentition.
Yeah.
They're the most developing.
Okay, epiglottitis, scary, bad. Can happen in kids and adults, guys. Don't think that can't happen in adults. Abrupt blockage of the upper airway, potentially death. Not nice. It progresses very rapidly. Not good, guys. Haemophilus influenza, the main cause. So give that vaccine, guys. We don't see epiglottitis that much anymore because kids are being vaccinated. So the ones that aren't, they're not probably going to get this. Sorry, that's really bad to say. So yeah. So they're going to have all the signs of respiratory distress. They're going to be tripoding. They're going to be drooling. They can't swallow. Really high fever. They're just going to be, even when you see a sick child, they're just going to be sick. They're not going to be well. That hot potato muffled voice, don't get them to speak, guys. Just leave them be. Their body's going to be doing what it needs to do to keep him alive. And do not examine the throat, even in adults. Do not examine. Just don't. If you think it's happening, call ENT, call anesthetics. We need to secure that airway. That's sorry.
What happens to you?
So, in adults, if you try and get them to open their mouth, their whole anatomy changes. They might be putting more pressure on their airway, and their epiglottis, which is already inflamed, is going to close. In children, if you try and examine them, they're going to cry anyway. So not only are they going to close it, but then they're crying, and then the crying causes, everything to happen, and you don't want that airway to close at any point. That's why. Yeah, high fever. They're going to be breathing really carefully, like they're going to be really trying to like breathe really carefully. They'll be hypoxic because they're not getting enough air, but they'll be tachycardic because obviously all this inflammation is going on. They're probably panicking as well. And so that'll be out proportion with their fever. Yeah. Rule out all other differential diagnoses. Have they had tonsillitis recently? Do they have croup? Like, have they had a cough? Ask parents, stuff like that. Secure the airway. Then to confirm diagnosis, you can do video laryngoscopy, and then you can do a throat swab to isolate the causative organism. You can do a lateral X-ray. I don't really think that people really do it, and it shows this thumb sign. The thumb being like there, and that's the epiglottis itself being inflamed, like that. Wait, I'll show you on here, like that. Yeah, cool. Secure the airway, then IV antibiotics, usually cefuroxime. And then you can give sometimes nebulized adrenaline to help vasoconstrict. And IV dexamethasone again for anti-inflammatory purposes. IV fluids, because if you think about it, they're probably not eaten or drank anything. They're probably drooling. and not good. Reflux laryngitis, sometimes acid reflux can go so far as the larynx. It can be known as silent reflux because you don't really get heartburn or indigestion. Weak voice, chronic cough, maybe excess phlegm, acid taste in the mouth because it's going all the way up. Yeah, might be burping a lot. That's it. PPIs, guys, antacids, change your lifestyle. Don't eat fatty, spicy foods. Try and drink less caffeine. Yeah. Right. Vocal cord nodules, polyps. Nodules, benign, small, they're keratin. So they're going to be a little bit white, a little bit pink, right? Shouldn't be a different color. And they're usually at the point where the vocal cords touch the most because all that rubbing is going to basically cause these nodules to form. Like singers can get it if you're screaming a lot, if you're shouting a lot, if you're coughing a lot, you can get it. Hoarse voice, very breathy, lower pitched. You can do voice therapy when they're small, and that's just to help like maneuver your vocal cords in a way that you're not putting so much tension on, that area. If it's untreated, it might keep growing in size, and then you might need surgery and then vocal therapy again. Polyps are usually benign, but they're usually unilateral. So nodules will be bilateral, polyps are going to be unilateral. Yeah, often related to smoking, guys. So also don't do that again. OSA, basically, the when you sleep at night, all your muscles become like hypotonic. Not fully hypotonic, but just less tonic. And the amount of force that you are able to give from your muscles, if that's exceeded by external forces, such as like if you have a really high BMI, that's going to be pushing down on your neck. Or if you have a really large neck circumference, that's going to be pushing down. So those forces are not balanced anymore. And so then you're going to get like uh, apneic episodes, which is basically like you don't breathe for a bit. When you don't breathe, your body's like, oh my God, what the hell's happening? You wake up. So they'll have very disrupted sleep. They won't be good. It'll be worse when they're sleeping on their back. Um, and yeah, they'll be really sleepy in the daytime. And children, when they're sleeping in the daytime, they're also cranky. So if you've got some kid with behavioral issues, and you hear them snoring at night, they might actually have OSA. You want to refer them for a sleep clinic. And if it's affecting their job, make sure they make amends to that job. If it involves machinery or a car, make sure that that's also sorted out. Um, Usually other things like COPD can cause it. If they're really high BMI, sort those things out, right? You can wait. Yeah, you can give CPAP in COPD at nighttime for like obstructive sleep app. Not in COPD, sorry. At nighttime. Not COPD, guys. Don't give CPAP in COPD. You can give it at nighttime to help them. It can be nasal or over the nose and mouth, but compliance is very poor, usually because the mask is not very well fitting, or because it's high pressure the whole time. Feels awful. Yeah, poor. Bronchial versus thyroglossus, we're almost done, guys. Both congenital, both slow growing. Branchial is more noticeable after a URTI, but not necessarily bigger. Whereas a thyroglossul cyst might grow rapidly after an upper respiratory tract infection. Thyroglossul cysts, right? Thyroid, glossal, tongue. Anywhere in between can happen. Yeah. And if you think about it, when you move your tongue out, if it's thyroglossal, if you move your tongue, it's going to move with your tongue. So if you stick your tongue out, it's going to move with it. So that's the thing in the thyroid exam where you're like, can you stick your tongue out for me, please? And if it moves, then you know it's a thyroglossal cyst. It's usually midline, well developed, not tender, can usually, midline, but can be a bit lateral, and might become infected as a secondary infection. Yeah, cool. Branchial cysts are from the first to fourth pharyngeal clefts. So these are the clefts. Usually they close, right? But the first top two are first pharyngeal clefts. The second one is the most common, where you might see a branchial cyst, and then the third and fourth are also there. But second is like most cases are second. Um, cool. Vocal cord paralysis. Um, yeah, basically, if they've had an infection, stroke, head trauma, surgery that damaged the nerve, you might have a laryngeal nerve, a recurrent laryngeal nerve injury. Most of the like muscles you use to speak are innervated by the laryngeal nerve, recurrent laryngeal nerve. So you might have a bovine cough, weak sounded voice, a variable tone of your voice, reduced volume, noisy breathing. It can recover on its own over time, or it can be irreversible, which is very sad. And voice therapy might help. Well, these are some outliers to look at that I couldn't cover in today's session and also are overlapped with other things anyway. Um, yeah, that's it, guys. That's it. Thank you. Please give feedback. That ended up being quite rushed, but I hope I covered most things and I hope I explained it pretty decently. Yeah, and also if these slides are made for like revision, everything from like nice guidelines is condensed onto one slide so that you can just like look at that. Cool. Please give feedback. Thank you. Thanks. Thank you. Yeah. Well done, honey bun.